Good afternoon. My name is Carole DeFelice. I am a ThyCa volunteer. I'm here to introduce Carole Spencer. She's a professor of research medicine at the University of Southern California. Carole graduated with an applied biochemistry degree from Bath University, UK, later a PhD from Glasgow University. She joined the University of Southern California to direct the Clinical Research Center Core Laboratory with a mandate to develop endocrine assays. Dr. Spencer's research at USC has focused on integrating the clinical with the laboratory aspects of thyroid disease and treatment. Dr. Spencer is a past president of the American Thyroid Association and currently holds the rank of Professor of Research Medicine in the Department of Medicine at USC. She's a licensed medical technologist and a technical director of the USC Endocrine Lab that specializes in measuring the thyroid cancer tumor markers, thyroglobulin and thyroglobulin autoantibodies. During her career, she has published over 100 scientific papers focused on the technical and clinical aspects of thyroid testing. Dr. Spencer is a thyroid medical advisor.
Thank you. Well, I'm sorry I can't be with you all there in person, but what I thought I'd do is show about 20 slides to kind of set the stage, and then if anyone has any questions, I'd be very happy to answer them. So what I'm going to review this afternoon is the two differentiated thyroid cancer tumor markers, thyroglobulin and thyroglobulin autoantibodies. So as no doubt you've been hearing today, the thyroid is a fairly small gland that's in the central part of the front of the neck. And the job of the thyroid gland is to make thyroid hormones, thyroxine T4 and triiodothyronine T3. And these critical hormones are made within the thyroglobulin molecule and are secreted into the blood. And as a consequence of this synthesis and secretion, some thyroglobulin is also secreted into the blood. Now, of course, if you've got no thyroid gland, because thyroglobulin can only be measured in the thyroid, you should have 0 thyroglobulin. But that is not always the case, as you know. So, what is thyroglobulin? It's a very large protein that's made uniquely by thyroid cells. The thyroid hormones are made within and secreted from the thyroglobulin molecules, and some thyroglobulin enters the blood along with the thyroid hormones. Now, most differentiated thyroid cancers also make and secrete thyroglobulin, but the thyroglobulin secreted by these tumors may be abnormal in structure and may circulate in different forms that may be detected differently by different thyroglobulin methods. Now, one big problem is that between 20 and 25% of thyroid cancer patients have thyroglobulin antibodies circulating in their blood. And these antibodies can interfere with the thyroglobulin measured by some of the methodologies we use to measure thyroglobulin. So when monitoring patients with thyroid cancer, the primary tumor marker in blood is thyroglobulin. In those patients with thyroglobulin antibodies detected, both thyroglobulin and the thyroglobulin antibody levels are monitored as tumor markers. And it's the trend in the blood tumor marker levels that is considered more clinically useful than a single measurement. And again, when thyroglobulin antibodies are present, the thyroglobulin antibody trend is maybe more important than thyroglobulin and considered more reliable, because the thyroglobulin antibodies interfere with some thyroglobulin methods, which I'll be describing a little later. So when you look at thyroglobulin, you're looking at the numbers. Well, the normal reference range for somebody that's had no thyroid surgery, that is perfectly normal, they have a thyroglobulin between about 3 and 40. Now, of course, most thyroid cancer patients have had their thyroid removed, and the thyroglobulin is usually much lower than that. So it's been important to develop assays with sensitivity to measure very low thyroglobulin. The first generation of assays, we call first generation assays, had a functional sensitivity between 0.5 and 1, and some assays still have sensitivity at this level. What revolutionized thyroglobulin testing is that around about 1990, 1995, a second generation of more sensitive assays became available. These could measure down to 0.1, and most current assays can achieve this level of sensitivity. There could, of course, be another magnitude more sensitive assays measuring down to 0.01, but it's not clear if these would offer any clinical benefit. Now, there are three main factors that control the blood thyroglobulin concentration: the mass, or the amount of thyroid tissue that's remaining. This is both the normal remnant left after the surgery, plus any tumor. Any sort of thyroid injury will release thyroglobulin into the blood, surgery or the damage caused, say, by a biopsy. And then, of course, TSH stimulation of the thyroid is a big factor to influence the blood thyroglobulin concentration. Now, before the sensitive thyroglobulin methods were developed, recombinant human TSH was given to boost the thyroglobulin levels into the measurable range. But now we find that recombinant TSH stimulation is unnecessary, since, as you can see by this figure showing the correlation between the basal thyroglobulin and the recombinant TSH stimulated thyroglobulin, there is a very strong relationship. So there's about a 10-fold difference between basal thyroglobulin, measured when the TSH is low, versus the recombinant TSH stimulated thyroglobulin. So in view of this strong relationship, if you can measure the basal thyroglobulin reliably with these more sensitive assays, you don't need to do recombinant TSH stimulation. So a patient always has two measurements made in their blood. Thyroglobulin is measured in a panel with the thyroglobulin antibodies to assess the potential for thyroglobulin antibody interference with the thyroglobulin measurement. Now, how common are these antibodies present? Well, in the general population, about 11% of people have got thyroglobulin antibodies. But in thyroid cancer patients, it is about double that. So when you've got thyroglobulin antibodies interfering with the ability to get a reliable thyroglobulin measurement, this is going to be quite a big problem for thyroid cancer patients. The other problem we have with these thyroglobulin antibodies is the methods we use to measure them, because the methods vary in specificity and the numeric values that they report. So what you see in this study along the bottom is 4 different assays: the Cronus assay, which we use in our lab, which was the reference, the Roche, the Beckman, and the Siemens. And as you can see, these 144 thyroid cancer sera with antibodies gave very different values depending on which method was used. In fact, the methods could differ by about 100-fold. The other problem is that manufacturers publish a cutoff for which they consider to be a positive antibody test. And these are set far higher than the sensitivity of the methods, these manufacturer cutoffs. So this is not very helpful, and what should be used to determine if there is a detectable thyroglobulin is the functional sensitivity of the method, which, as you can see, is very different for each of these tests. And then you can see some methods suffer from insensitivity. The blood of one thyroglobulin antibody serum might be negative using another test. So there are some major problems with the thyroglobulin antibody methods that we use. The other thing is to remember that the trend in the tumor marker is more clinically relevant than a single measurement. And the trend in the antibody tests are particularly important because when a patient becomes disease-free, as you can see here, the patient started with antibodies detected by 2 different assays, and then as the treatment took effect and the patient was rendered disease-free, the thyroglobulin antibody levels go down. And this is a very good indicator of response. But notice that the absolute values, the numeric values reported by these 2 different antibody tests are very different. But what is evident is that the ratio between the 2 methods is fairly constant. So you can see the trend down is really very good. Patients with persistent disease usually experience a small decline in antibodies immediately after their surgery, and then the antibodies kind of plateau and level out. And again, the ratio remains pretty constant between the assays. And then in the right-hand panel, you see the antibody pattern in a patient that suffers a recurrence. But again, the ratio between the 2 methods that were used is relatively constant. So clearly, in order to measure the antibody trend, you've got to be using the same method. And I recognize this is not always possible. Laboratories sometimes change their methods due to contracting or the instruments they use. Sometimes the insurance company insists that you use a particular lab that might be using a different method. But if you have an opportunity to have your blood sample measured in the old method versus the new method, you can get the ratio that will allow you to correct your values to the new method. Now, turning to the thyroglobulin methodology issues, most thyroglobulin testing is made using immunometric assays. And people like these assays because they're rapid, they're automated, and they're relatively cheap. But the drawback to these assays is that they're prone to Tg antibody interference that causes falsely low or undetectable thyroglobulin to be reported, which in a patient with disease can be highly misleading. When Tg antibodies are detected, many labs reflex to the thyroglobulin testing away from the IMA method to the radioimmunoassay or the mass spec test, because these 2 methodologies are considered less prone to TG antibody interferences. So what I'm showing here are the three classes of thyroglobulin method. IMA, radioimmunoassay, RA, and the new mass spec test. There are a number of different commercial methods for the IMA. There are very few methods left for the RA because this is the older technology. And there are more methods being developed for the mass spec tests. Now, each of these methods have the potential for interference. First, by, you've probably heard, dietary biotin. High-dose dietary biotin can interfere with the IMA especially, causing falsely low values. You may also have heard of heterophile antibodies. These, again, with the IMA, the most popular test, cause falsely high values. And the prevalence of these heterophile antibodies is not insignificant. It's about 1 to 3%. Now, neither the RAA nor the mass spec tests are prone to either biotin or heterophile antibody interference. But as far as the TG antibody tests are concerned, the IMAs are affected, giving falsely low values. Some RAAs may be resistant to antibody interference. And the mass spec tests, when they came out with a lot of hype, claimed that they were not affected by TG antibody. But as I hope to show you, these claims are questionable. I don't think we need to worry too much about the biotin interference with the IMA because these have been mostly eliminated now. Now, this shows some of our data, and this is a paper that's currently in press in the Journal of Endocrinology, Clinical Endocrinology and Metabolism. And what this shows are thyroglobulin levels measured by, as you see on the lower axis, IMA, 4 different mass spec tests, and the USC RAA method. The panel on the left were patients with distant metastatic disease who were TG antibody negative. And as you can see, all but one patient had detectable thyroglobulins, and there were fairly good consistency between the different methods. But of course, you're looking at the thyroglobulin values on a log scale. So actually, some of these measurements between the methods on the same specimen were quite far apart. Now, what I want to point out is the problem with the thyroglobulin antibody positive patients. Again, these patients had distant metastatic disease. The patients shown in open symbols had actually died of their disease, but you can see that the thyroglobulin values measured out were highly discordant, with many patients with supposedly undetectable thyroglobulin measured by IMA and the mass spec test. Only one had an undetectable thyroglobulin using the RAA test. And these, as I stress, are all patients with distant metastatic disease who you would not expect the thyroglobulin to be undetectable in. So this is the major problem of the IMA methodologies and all the mass spec methodologies. They are prone to give undetectable thyroglobulin values in the presence of the thyroglobulin antibodies, despite patients having severe disease. So the thing is, even when you're using a mass spec test, and there are a number of them, you have to stick with the same method in order to be able to monitor the trend in the thyroglobulin, because changing methods is going to disrupt monitoring. So this is an example of a patient who had a large tumor, received a thyroidectomy here at time 0, had a number of lymph nodes, and the thyroglobulin was not undetectable, was measured by the most popular test, the second generation IMA, and you can see the values were slowly beginning to climb by 2 years following the surgery, and then really seemed to take off. And after 3 years, a biopsy revealed stage 4 pulmonary metastasis. These same specimens were measured using an RIA shown in blue and 4 different mass spec tests. And you can see that the values of each of the specimens were quite different, about 2-fold different, in fact, depending on what method was used. So clearly, changing the thyroglobulin method when you're trying to monitor the trend is going to disrupt your monitoring. And just to note, in this patient, all specimens were antibody negative, so this antibody was not an issue. So we're going to be monitoring the trend in our thyroglobulin tumor marker. And the factors that are going to influence the trend, ones that we've got to try to control, besides changing them, besides keeping the same method, the trend will be influenced by changes in tumor mass, the efficiency of that individual patient's tumor to secrete thyroglobulin. Some tumors are very poor thyroglobulin secretors. Often these are the less well-differentiated tumors. You can't monitor the trend in thyroglobulin unless there's no elevation or major change in the TSH. So the importance of keeping the thyroxine medication constant is clear. And there should be no source of thyroid injury, like a biopsy or a second surgery. Otherwise, of course, thyroglobulin is going to rise. So optimal thyroid cancer monitoring depends on the patient, depends on a number of factors. In patients without thyroglobulin antibodies detected, you need to monitor the basal thyroglobulin trend without TSH stimulation using the sensitive second generation IMA method. Usually the functional sensitivity is around 0.1. But in patients with thyroglobulin antibodies detected, monitor the thyroglobulin antibody trend as the primary, albeit a surrogate tumor marker. Monitor both the thyroglobulin and the thyroglobulin antibody trends if you can detect thyroglobulin by any method, because sometimes the thyroglobulin antibody falls as the thyroglobulin rises with progressive disease. You wouldn't want to miss that thyroglobulin rise. Now, why the new mass spec methods fail to detect thyroglobulin in over 50% of antibody-positive patients with structural disease is a question that needs further investigation. But the bottom line is you need to use the same thyroglobulin and thyroglobulin antibody methods, preferably in the same laboratory. So there are a number of technical challenges that impact the clinical utility of thyroglobulin and thyroglobulin antibody testing. You've got 3 thyroglobulin methodologies that vary in sensitivity, specificity, and interferences. Only the 2nd generation IMA has the sensitivity to obviate the need for recombinant TSH stimulation. The blood thyroglobulin trend without TSH stimulation, TSH something below 1 milli-unit per liter, is used in preference to a fixed thyroglobulin cutoff. You can only monitor the blood thyroglobulin trend by using the same method, and thyroglobulin interferences are either non-specific, biotin, heterophile antibodies, or specific thyroglobulin antibodies. Labs often prefer to measure thyroglobulin when thyroglobulin antibody is positive by RAA or mass spec, and if thyroglobulin antibody is positive, the thyroglobulin levels can be unreliable by any method. The thyroglobulin antibody trend is a surrogate tumor marker and is often more reliable than the thyroglobulin, depending on what methods you've got available to you. And thyroglobulin antibody method continuity is critical because different methods vary 100-fold in what they report. So that is my last slide, and I'd be very happy to entertain any questions.
In number 3 on your last slide, you said something about the TG trend with TSH less than 1. I'd never heard of TSH level affecting the thyroglobulin measurement, does it?
Well, the TSH is a major stimulator of thyroglobulin. You saw how recombinant TSH will make thyroglobulin shoot up tenfold. So not all thyroid cancer patients are maintained on TSH suppression. Usually the thyroxine is adjusted so that the TSH is in the low range, maybe around about 1 or below. But what is key is that the TSH needs to be maintained at that level, so compliance with the thyroxine dose is important.
I have a few questions from the virtual audience. Initially, this may have been really answered, but anyway, it says, when you talk about levels, please also give the levels for people who have had a hemithyroidectomy. Will they differ from a total thyroidectomy?
Yes, they will. I have a feeling my colleague, Dr. Angel, might have talked about this morning. They will differ. The average size of the thyroid is, say, 20 grams, and the average thyroglobulin level that is produced from those 20 grams is something like, say, 15. So if you have a hemithyroidectomy and you've got one normal lobe of about, say, 10 grams left, you would be expecting the thyroglobulin to be round about 7, as long as the TSH is not elevated. So if the TSH is maintained normal, but whatever the thyroglobulin settles down to after the hemithyroidectomy, once the thyroxine, if there is thyroxine given, is stabilized, then that is that number that patient should follow. There is no magic cutoff that they found. Obviously, if you've had a hemithyroidectomy and you're hoping all the tumor's gone, it would be surprising to find a very high thyroglobulin in the absence of TSH stimulation. That would be worrisome if after the surgery the thyroglobulin didn't come down significantly. we always do a pre-op thyroglobulin for just that reason, to get some idea of the efficiency of the tumor being able to make thyroglobulin. For example, some poorly differentiated tumors are not very efficient thyroglobulin secretors. So we've seen patients with, their neck full of tumor, but the thyroglobulins only say 30 or 40. And that pre-op thyroglobulin tells you something, that tumor is probably not that well differentiated and not able to make a lot of thyroglobulin. And so the confidence you would have in your thyroglobulin monitoring would be decreased in that situation.
And also in the virtual audience, Katie asked if the USC lab is best for the thyroglobulin testing.
Well, the USC lab, this has been our research focus for, several decades. We measure thyroglobulin by both the IMA method, the second generation IMA, and the older radioimmunoassay. And we don't measure by mass spec because, as I showed you, the problems there are, well, it's very expensive. And if it isn't going to give you more reliable values in the presence of thyroglobulin antibodies, in our view, there's no advantage in setting it up. So what we do is we use the Cronus TG antibody test. If there are antibodies present, we measure the thyroglobulin by the radioimmunoassay. And if you want to look at our paper, which is about to come out, and anybody that's interested to see it can email me, I'll send you a copy. But the RIA does appear to give very valid and clinically useful thyroglobulin results in the presence of antibodies, whereas the IMA gives the undetectable values, same as the mass spec. The other thing the USC lab does really pretty uniquely, we never throw a specimen away. We always bank the specimens in our freezers because we give physicians the option to request concurrent remeasurement of a pass with the current specimen. Now, just about any test you measure in the lab has got variability day to day, week to week, month to month. You can have all kinds of factors that cause the test to vary a little. The batch of reagents the manufacturer sends you, the temperature in the lab, all sorts of factors can affect the test result to, between 10 and 15%. But if you've got the previous specimen from the patient and you can measure it back to back in the same assay, you can very reliably detect whether there has been a change. So we probably got over 15 years worth of specimens in our freezers from our patients. And we do this with the concurrent remeasurement with both the thyroglobulin antibody test and the thyroglobulin test. And this is something that we do uniquely and feel, as our clients feel, is very valuable.
Hi, Professor Spencer. I encountered thyroglobulin puzzle recently. Let me briefly introduce my case. 22 years ago, I have the thyroidectomy and followed by the radioactive iodine-131 treatment. And after that, for the 22 years, both the thyroglobulin and thyroglobulin antibody were negative. And later on, starting from year 23, the thyroglobulin level started to rising. But antibody up to last month, thyroglobulin antibody are always negative. And the provider did the both PET-CT and the bone scan. They do not show any solid cancer cell. Well, they are puzzled, now, for basically for about the 2 years, the TG level now is hanging around about from 3 to highest is 6.1. Is up and down on this level, and one provider said that they cannot take action based on only on the TG level, and because they cannot find the tumor. And well, some other providers say that then maybe you have the numerous small spot of the cancer. They cannot see the tumor size, and when you accumulate numerous the cancer cell, and then they produce the thyroglobulin level. So well, I was puzzled about what is the TG level trend, and what causes this level in a situation when the TG level is high, hanging around the 5 or 6. However, PET-CT and the bone scan shows negative. Thank you.
Okay, and did you have a radioactive iodine scan as well?
No. Oh, well, one more thing. Recently, the provider did the mutation test, and
Okay.
it proved that my papillary cancer has the BRAF V600E mutation.
Yes.
They
Yes.
told me this mutation has the strong tendency have the radioactive iodine refracture. So they say for this case, and unlikely, they will, respond to the radioactive iodine.
Yes. Well, it sounds, if I've got it right, that you've had thyroid cancer treatment for a long time now, and the thyroglobulin is staying in the 5-6 range, but your thyroglobulin antibodies are negative, and they haven't found anything with CT and other types of scanning. Is that right?
Yeah, you heard that correctly, doctor.
Yes, yeah. So, I mean, one thing that might be worthwhile, because as I mentioned, one thing that would cause a falsely high TG is the heterophile antibodies, and that's the test that we do. And it might be a long shot to see if perhaps it's a heterophile antibody contamination, but it's in your situation, it would be perhaps worthwhile doing. Now, heterophile antibodies can occur in a lot of people, especially if they're exposed to animals. So I don't know what your, profession is, but, that is perhaps worthwhile if they can't pin down the fact that the TG is coming from a tumor.
Thank you. We have another question here in the audience.
So quick question, if someone has mildly elevated thyroglobulin before surgery, so let's say if the upper level is 240, let's say someone has 50 or 60 before surgery, and then half is removed, what is the realistic expectation should the cancer be removed in that one half of the test afterwards? Should that be still around 15?
Yes, of course, it all depends again on the TSH, because quite often after surgery, even if you've got a lobe there making enough thyroid hormone, it can sometimes take a while for the production of the thyroid hormone from the remaining lobe to ramp up. And during that ramping up, you can get more thyroglobulin produced. So it depends on the TSH and where the thyroglobulin settles out after, say, a lobectomy is going to be an individual thing. What is more important is whether it changes with time. Now, because often people have a lobectomy because they think they won't need to take thyroid hormone. But sometimes because the remaining lobe has to work harder, then the thyroglobulin goes up and gets people a little worried because the lobe will start to hypertrophy to meet the thyroid hormone need. So it's a very individual thing. Of course, if your pre-op thyroglobulin is 50 and you're hoping a lot of that has been removed as tumor, so maybe you come down to 20-something, but then that becomes your new baseline and you have to watch the TSH and again, look for the trend.
I have a question from a virtual, their background, they said they have done TT and RAI last year and have an increase in TG this year and currently advised to visit an oncologist for confirmation. Their question was, does TG, ANA, and ESR have any connection? Are there any additional tests they would have to take?
I don't think so, not for thyroid-related issues. I have not heard of needing other types of testing, just the thyroglobulin antibody test. Although, as I mentioned to the other gentleman, if the thyroglobulin looks like it's strangely high and there's no disease apparent, it's worth looking to see if interference by a heterophile antibody. But heterophile antibodies only interfere with the IMA method.
We have one more question in the audience.
Dr. Spencer, I've heard that when we have radioactive iodine treatment, that can cause a rise in TG before it falls as the tissue is dying off. Is what we've heard correct? And then how long does it take for it to rise and then drop?
Yes, that's definitely one of the three factors that influences TG is damage, which you would get with radioiodine. And it's probably going to take, I think there are papers on this, I can't pull them up in my mind at the moment, but, of the order of months. The half-life of thyroglobulin is about, is up to a week or something. So things don't happen immediately. The damage is progressive and ongoing, I think, for a couple of months. And it's probably going to be over the first 6 months, things will stabilize, is my guess. But there are papers that have looked at that question.
I had papillary thyroid cancer, but I was Now looking at some labs of mine, and with my thyroglobulin antibodies, from my diagnosis 2014 to 2019, the range that they were using for the antibodies was 0 to 40. But then in 2019, the range went from 0.9 to 3.9. What does that do to my trend? And because
Well, that means they switch methods. They switched from the Roche
okay.
method to the Beckman method because the manufacturer cutoff of the Roche was 40 and the manufacturer cutoff of the Beckman is 4. And that is not, very, you can't really look at that. So what is the level of your antibodies at the moment?
At the moment, let me look, because in 2019 at my 5th year cancer mark, I was told they were detectable for the first time. So I'm trying to find at the moment, but yeah, I can't. I think the last it said
right.
low. It said low at the low end of the range. I think it was the less than 0.9, I believe. That was in
Okay, well,
2019. So
yeah, that's negative. Less than 0.9 is negative on the Beckman assay, which the majority of the commercial labs use.
okay.
So
Thank you.
so that's helpful.
Thank you for explaining they changed the methods. I didn't know that.
Another virtual question. It said, my wife has had a complete thyroidectomy and radioactive iodine treatment, but is still showing a thyroglobulin of 7 to 8 range 6 months out. She has done an ultrasound and subsequent radioactive iodine scan, which were both negative. We have a PET scan coming up. Is it possible that the thyroglobulin levels stay at this 6 to 8 range for a long period of time without worry?
Well, that's one of those cases it would be worthwhile to just check it's really thyroglobulin, get a heterophile antibody. Make sure that it's not that type of antibody interfering. And if things are stable, even if the thyroglobulin is coming from a small amount of tumor, then that's what you're going to be watching with the trend. If they've done all they can to pinpoint whether it's the source of it, and if it's really thyroglobulin, then that's your baseline that you'll be monitoring.
Hello, doctor. Hello, doctor. I'm just wondering if I can use thyroglobulin as a tumor marker. I had diagnosed with poorly differentiated thyroid cancer. I had a total thyroidectomy. Pre-op, my thyroglobulin levels were over 450. Since then, my thyroglobulin has been undetectable. THS is suppressed, and my antibodies are also undetectable. I do have lung mets, so I'm wondering, can I use thyroglobulin as a tumor marker for progression?
Well, it sounded as if the thyroglobulin was high before you had your surgery. And if that's the case, that suggests that the tumor is capable of making thyroglobulin. And the fact that it's come down low should be a good sign. Although with lung mets, you usually have higher levels of thyroglobulin. So I'm not quite sure, what to tell you there.
Okay, thank you.
We have one more question.
Hi, I also had a question related to a partial thyroidectomy. I'm just curious if my levels have not decreased at all following a partial thyroidectomy. So for example, if it was like 11 pre-surgery, and then it's still around 11 after surgery, and even increased up to like 17 post-surgery. Is it normal for it to stay the same and never decrease, or should you always expect it to decrease once 60% of the thyroid is removed?
Well, I mean, if you've removed 60% of the thyroid, the remaining lobe is having to work a lot harder, at least initially, till it kind of builds up the mass to be able to supply enough thyroid hormone. And with that hypertrophy and the growing of the remaining lobe, it's going to take a while to settle down at a new level. I mean, it may be that it needs to grow up to the same mass as it was initially. You've removed the tumor, but now what's left is having to work harder. And that's going to take quite some months to stabilize and for you to see where you are, and maybe get ultrasounds to make sure that there's no other lymph nodes or other tumor there. So it will take time. And of course, during that time, the TSH needs to be kept at a reasonable level, say around about 1 or 2, whatever. If you don't replace the TSH, and a lot of people think that with just taking the lobe out, they're not going to need thyroid hormone. It depends how well the remaining lobe compensates. So the TSH is an important part of the equation as well.
Thank you.
Thank you very much, Dr. Spencer, for this very informative session. I think we will end at this point. Thank you.
Oh,